Okay, we're going to go ahead and get started. Welcome. We're so glad so many of you could make the time to join us today. I'm Jennifer Martinez. I'm the CEO of the ARC of Texas. A few housekeeping items before we dive in. This webinar is being recorded. Registrants will receive an email by tomorrow with this recording, and it will include the slides that you'll see today. There will not be a live chat box today since we're keeping the discussion to a very tight hour. But I will be asking a few follow-up questions of our presenters at the end of their presentation. So let's get started. Last fall, following months of research and interviews with individuals living and working at the intersection of intellectual and developmental disabilities and mental illness, the ARC of Texas released an in-depth investigative report called Out of Options, addressing inequities and care for Texans with IDD and mental illness. This work is part of our Whole Person Project, which seeks to expand access to mental health care for adult Texans with IDD and is supported by the Texas Council for Developmental Disabilities. We partnered with Alex Stuckey, our author of the report and a Pulitzer Prize winning investigative journalist from Houston, to collaborate with us as we set our sights on better understanding the realities faced by folks with this dual diagnosis. As well, Sabrina Gonzalez-Saucedo, Director of Public Policy and Advocacy for the ARC of Texas, is with us and has a pulse on the related considerations at the legislature. They have a lot to share, so without further ado, I'll turn it over to the two of you.
Hi, everyone. We're really excited to do this webinar. I'm first just going to kind of explain a little bit about how we came to the findings that we're going to be presenting and that can be found in the report. So I had spent the better part of a decade writing about mental health care and in the state of Texas and services for people with IDD. And, I just kind of got sucked in and was writing a lot about this because there are so many areas of improvement, we'll say. So when the ARC reached out to me about doing this report, I was really excited about it and was able to kind of build on this decade of knowledge that's kind of stuck in my brain at this point. So to really hone in on kind of key places where we saw gaps in services for people who have co-occurring mental health and IDD. We talked to, dozens upon dozens of people, from advocates to families to people working in the state. We utilize social media to find people. We utilize advocates to find families to talk to. And so in doing all of that, we kind of came upon 11 areas where there are some gaps in services for people that do sort of have this dual diagnosis. But that's a lot to cover in an hour. So we're going to focus on kind of three areas today. And so those three areas are the lack of funding, what has happened because of this lack of funding, and some ways that we can address this and make services better for people. So I'll go ahead and turn it over to Sabrina to talk about some of the funding issues.
Awesome. Thank you so much, Jennifer and Alex, and all of you for being here today. As Alex just outlined, this report sheds light on the many gaps in services for people with co-occurring intellectual and developmental disabilities and mental illness. And one of the biggest contributors to these gaps is the chronic lack of funding for the programs and services that are meant to support this population. And to understand where we are today, we have to look back at budget cuts that have contributed to where we are today. In the early 2000s, Texas lawmakers made deep budget cuts that left long-term damage. In 2003, $100 million was slashed from community mental health services, which significantly limited access and shifted the burden onto emergency rooms and jails. Fast forward to 2011, nearly $60 million was cut from general revenue funded services for people with IDD that were provided by local IDD authorities. And this similarly exacerbated already lengthy wait lists, some now stretching as long as 17 years. These cuts didn't just affect funding, they reshaped the system itself and has left individuals and families without adequate options for care. And when people don't get the services they need, the consequences can be devastating, as Alex will explain.
Yeah, so as Sabrina mentioned, these, they seem like relatively small cuts in the grand scheme of things, but these cuts to the budget were so fundamental to creating these extreme wait lists we're facing. And if you talk to most people at local IDD authorities and local mental health authorities, they will say, we have not recovered from this, and it's been a really long time. So one of the things that has really, the budget cuts have really contributed to is this wait list for Medicaid waivers that Texas uses. And if you don't know what a Medicaid waiver is, community-based services and other healthcare needs for people who have IDD. And it basically allows them to live in the community instead of an institution, which is, of course, the goal at all times. And we have 6 Medicaid waivers that we have access to. So the problem is there are more than 176,000 people waiting for care through one or more of these wait lists, one or more of these waivers, which is 73% more than in 2015. And in that time, the enrollment for those programs has only increased by 1/3. So as you can see, we're not keeping up with the demand by adding more spots for people. And then, of course, our population is just burgeoning and continues to burgeon. And so that creates a problem as well. So we're just not keeping up. And on top of that, we have closures of group homes because personal care attendant pay is so low. So there are 300,000 personal care attendants in Texas, and they only make $10.60 an hour. And these are people who are doing the hardest jobs imaginable, frankly, right? They are literally doing everything to keep people alive and living in their homes. So toileting, bathing, making sure they're fed, all those kinds of things, which are all really important. We did have a slight increase in pay from $8.11 an hour to $10.60 an hour, but it's not enough, obviously. And advocates have really been pushing to 20 not happen. And when you look across the country, only Louisiana pays their personal care attendants less than Texas. And because of this, there have been several surveys done recently that have shown that, the staff vacancy rate is really high in group homes that employ personal care attendants, and staff is working extreme overtime to fill that gap. And a lot of providers, even though they're technically not allowed to, are having to turn away referrals of people because they just don't have the staff to maintain. And because of this, group homes are closing. During this survey that I was speaking of, which was December 2022 to January 2023, 7 ICF providers and 27 HCS providers permanently closed group homes because they could not keep them staffed. And 6 others said they were canceling contracts, and many others were just anticipating these closures because they could not recruit and retain staff. And part of the problem here is that personal care attendants who work in state-supported living centers are making way more. So state-supported living center state-supported living center personal care attendants are making $17.50 to $21 an hour, which is significantly more. Still not enough, but significantly more. And so you are seeing a loss of people from the group home setting because they're going to the state-supported living centers so that they can make a more livable wage. Another issue here is that the state doesn't require people that work in group homes, including personal care attendants, to take any kind of mental health training. So as we're seeing more people with IDD present with mental health issues, they're going to group homes, and the people that work there are not equipped to handle their behaviors. And so that's another reason that personal care attendants are leaving those group homes. And so because of all this and many more things, more people are finding themselves in need of institutionalized care, including public psychiatric hospitals and SSLCs. And so as a result, we are seeing people turn to private care, which is largely inaccessible. And Sabrina, if you could change the slide. Thank you. So we're seeing people have to turn to private care, which is not really accessible in the state of Texas. So one of the reasons this is happening is very few colleges and universities have IDD programs. So already Texas is really low on mental health care workers, and 97% of our counties are federally designated as complete or partial shortage areas of mental health care providers. But that amount gets even lower when you look at therapists or counselors or social workers who can work with people who have mental health issues and have a diagnosis of IDD. As part of this report, we reached out to 18 Texas colleges and universities who have math or doctoral psychology programs with a clinical component, and just any kind of program in place that would offer services and IDD training beyond assessment and diagnosis. So those two universities were Abilene Christian and Texas A&M. So Abilene Christian has a kind of a creative approach to help people work with individuals with IDD. So for example, to help treat people with IDD who have anxiety, because it helps them get exposure and manage their fears for social situations without actually having to go into those social situations. And then at Texas A&M, doctoral students have to have at least 5 semesters of assessment practicum that includes training and therapy services for people with IDD. However, that is not a true IDD program in either of those cases. Also problematic is that at least 10 private psychiatric hospitals across the state won't admit people with IQs under 70. We surveyed 25 private psychiatric hospitals, and those 10 very specifically said we will not accept people under that IQ number, which leaves out most people because only individuals with an IQ lower than 70 are even eligible for Medicaid waiver services. So you're looking at 110,000 people that just cannot even enter the doors of these private psychiatric hospitals. Even more of these private psychiatric hospitals we talked to said that they will not accept someone if they can't participate in group therapy or complete daily living activities, which, as you know, also kind of brings in more people with IDD that fall into that category. There is one hospital, Rio Vista in El Paso, that while we were working on the report was opening a unit for people who have IDD and mental health, dual diagnosis. So that's a step, but that's also El Paso. There are lots of other places in the state that need the services. And then also because of the inaccessibility to care, you're seeing more individuals with IDD and mental health care interacting with law enforcement and not being identified as having these diagnoses. So, for example, one option, if somebody interacts with law enforcement, and let's say they're doing kind of that classic mental health situation where you're just picking someone up for trespassing because they're homeless or something like that, you could send that person to a jail diversion center or a drop-off center that would get them connected to the services they need, whether that be medication or an appointment with their therapist, or in some cases employment help. and housing help, but only 62 counties in the state have one of these centers, and often they are underutilized. So Harris Center has a pretty good program, as does Texana Center in Rosenberg, but Tarrant County has a jail diversion center that is super underutilized. So the center opened in January 2022, and it can admit 30 to 40 people each day. But in the first year that it opened, they were getting maybe 30 admissions per month. And it was such a problem that the county sheriff even wrote a letter to the center's advisory committee saying that, like, we have a lot of people who would qualify for this center in our jails, and they're just not being sent there. And Dallas County has had kind of similar issues with utilization. So they also opened their center in 2022. And the goal was to serve 450 people in its first year, but immediately they were struggling. And when there was kind of a look at why this was happening in 2023, so a couple months after they opened, the leadership team of the center determined that frontline officers didn't even know that the center existed, and they hadn't seen a training video or a bulletin about what the center did and who could be sent there, that sort of thing. So this is, while these diversion centers where they are, it's so important, that training aspect is even more important, because if people don't know how to identify someone who has one of these diagnoses, or they don't even know it exists, you can't send people there, and then they're winding up in jail. Another issue here is that county jail screenings don't capture everybody that has mental health or IDD issues. So in 2007, the legislature passed a bill that would require there to be a screening of everyone that went into a county jail within a certain period of time. That's called the continuity of care query. And basically, it would screen people to see if they had ever received mental health services from public entities within the past 3 years. So think a public psychiatric hospital, a local mental health authority, a state-funded contracted private psych bed, those kinds of things. All the jails were using it by 2013, but IDD wasn't added to that search until 2020, so 5 years ago. And another issue here is that it's the same, right? It's 3 years and it's publicly funded services. So already you're missing a huge group of people that have either never gotten services, or they are getting services from the private sector in some way, like, for example, IEPs in schools, and that is just not covered under this search. Also problematic is that local mental health authorities and local IDD authorities are supposed to get alerted pretty quickly that one of their clients has been flagged by the jail, so that they've walked into the jail. And from the LIDAs and the LMHAs that we surveyed, that was happening in a wide variety of time frames. So some said they were getting alerted in 24 hours. Some said it took a week. Some said it could take a month before they found out someone was in jail that had been receiving services through them. So this is obviously something that needs to be addressed, so that at least if someone has received those services and has entered the system, they can be helped, right? And another thing here that's happening is that people are interacting with law enforcement. They're not getting flagged. Obviously, some people are getting flagged, but they may not be getting flagged. And then they're waiting in jail for a public psychiatric bed after they're found incompetent to stand trial. So someone is found incompetent to stand trial. Let's say if they can't understand the charges against them, they can't communicate with their lawyer, and that, you can see people with mental health and ID. But the problem is that if a judge finds them incompetent, they are sent for competency restoration, and it's typically to a public psychiatric hospital. However, as of June of last year, there were almost 1,900 people waiting for a public psychiatric bed, which is 500% higher than in 2015. And so about 300 people at any given time were waiting in 2015, to give you a comparison. So 300 to almost 1,900 is pretty significant. And the average wait for a maximum security bed right now is more than a year, and about 6 months for a minimum security bed. So think maximum security bed would be for someone who committed a violent crime or is accused of committing a violent crime. So think assault, murder, rape, that kind of thing. And minimum security is more for kind of those low-level misdemeanors in general. That list, that almost 1,900, it is almost 100% people waiting for competency restoration. So lawmakers have been trying to put money into adding more beds. They have this multi-billion-dollar plan that they're working on, but it's just like, it's not keeping up with the demand. And so much of that is because we are not catching people early. We are kind of waiting for them to make their way through the criminal justice system to be like, oh, this person needs help. And if we just looked at services on the front end, that would really help this problem a lot. And, think about if all of these people are waiting for a competency restoration bed, that makes it really hard for people who just need like a civil commitment, like someone walking in off the street. I mean, they're not getting a public psychiatric bed either. So it has implications far beyond this population. And so just growing exponentially at this point. Lawmakers they've come up with several different alternatives to competency restoration in a public psychiatric bed setting. So for example, there's outpatient competency restoration, which means the person is allowed to live in the community and then they go to appointments where they are basically, there is some medication management, but competency restoration really focuses on, this is how you understand the charges against you. This is how you work with your lawyer. It's really kind of court education and not so much truly like, how can we make your brain better, right? And so there's outpatient competency restoration, and then there's jail-based competency restoration there. And only 27% of the state's counties have one of these restoration programs, which means there are 9 million people in the state who do not have access to an alternative for competency restoration. So that means if you're in a county that doesn't have one of these programs, you have no choice but to sit on a list in jail, continuing to decompensate while you're waiting for competency restoration, which, it's important to note that this population in particular, no matter what you do, they are not going to have their competency restored, right? They have a low IQ or that sort of thing. They shouldn't even be on a wait list, right? They should be funneled into services immediately. And through my reporting throughout the past decade, you just see time and time again that that's not happening. People are just sitting and waiting. They finally get a competency bed, and then, it comes back to the court that like this person can't reach competency. Like they just can't. And then they're released from jail, and then the cycle happens all over again. So there are many other things we talk about in our report. That's just kind of a quick overview. Not to leave you guys in an effort not to leave you guys on a sad note, Sabrina is going to talk about some of the solutions that could help address these issues.
Yes, definitely. We're going to be jumping into some of the recommendations that we have as a result of doing this deep dive and investigative report. We've identified some of the most significant issues impacting people with IDD and mental health needs and what is preventing them from accessing the care they deserve. But we're not here just to talk about these problems. We're also here to talk about solutions. And there are real actionable steps that Texas can take to close these gaps and to create a system that truly meets people where they are. And we've classified these steps into programmatic changes and investments. And so we're going to start with jumping into these programmatic recommendations that we identified. First, identifying people with IDD and mental health needs is key. And we recognize that there is a need to strengthen mental health screenings at local IDD authorities to identify when a person with IDD has a co-occurring mental health diagnosis. The goal here is to connect people with the appropriate care before they reach a crisis. And identifying someone as having a co-occurring mental health condition is key. Alongside that, we also believe that it's key to amplify county jail screenings so that when someone with IDD enters the criminal legal system, there's a thorough search for both private and public services that they've interacted with over their lifetime. This could help identify people who need support rather than incarceration, and could capture groups that could be better suited for restoration or jail diversion specifically. Another critical piece to this is training jail staff to work with people with IDD. Too often, people with IDD are misunderstood in these settings, and sometimes actions that are a manifestation of a disability are misconstrued or misunderstood and lead to unnecessary disciplinary action or prolonged stays. So training jailers on how to recognize and interact with this population can make a huge difference. Of course, a really important piece to this puzzle is prevention. And we wouldn't be able to have this conversation without acknowledging how critical it is to revamp the Medicaid waiver waitlist system to provide people with the critical supports they need to remain in their communities. And not have to wait until they end up in crisis situations, and without having to wait 17 years plus prior to being able to access these services. Further, we believe that law enforcement must be trained to interact with individuals with both IDD and mental health conditions so encounters don't escalate unnecessarily. Another barrier that Alex mentioned and identified in this report is exclusionary admission criteria at private psychiatric hospitals. This prevents people with IDD from getting the mental health care they need simply because their IQ is less than 70, or they're unable to complete tasks of daily living. And so we believe that removing these restrictions would open up critical treatment options to this really important co-occurring population of people with IDD and mental health needs. We also lastly think that it's important to focus on building the workforce. This includes training psychology students at colleges and universities to be able to work with people with IDD specifically. So future mental health professionals are prepared to serve this population. The last recommendation that we offer here programmatically is to expand Texas's outpatient biopsychosocial approach for IDD services, also known as OBI. OBI is a best practice approach that is specifically designed to meet the unique biological, social, and physical needs of people with IDD and mental health diagnoses, and ensure that they receive comprehensive, individualized care in their communities. This program started as a pilot and is currently being offered at 5 of the local IDD authorities across Texas, and expansion of this program would be incredibly helpful in meeting the needs of this population. These are just some of the programmatic solutions that lay the groundwork for a more effective system, but none of this can happen without financial investment. And so to begin to solve these inequities monetarily, there are also some investments in critical pieces that are important to acknowledge. As mentioned, there are clear actionable steps that we can take to strengthen our system and ensure people with IDD and mental health needs receive the care they deserve. None of these solutions exist in a vacuum, and they all require real investment. And so some of these investments need to look like investment in increased funding for Medicaid waiver programs so that people can reach access to home and community-based services before they reach a crisis. We also recognize the need to invest in public psychiatric hospitals. Texas has one of the lowest public psychiatric bed capacities in the country, and without enough beds, people in crisis end up in emergency rooms or jails, places that aren't equipped to meet their needs. Another critical area is in competency restoration alternatives, including outpatient and jail-based programs. Right now, people found incompetent to stand trial often wait months or years, sometimes over a year, for a state hospital bed. And expanding outpatient and jail-based restoration alternative programs would free up space in hospitals for people who truly need them, while ensuring individuals get the support they need faster. Further, we also need to fund diversion centers, which serve as alternatives to jail or emergency rooms for people in crisis. These centers, as Alex mentioned, provide immediate specialized care for individuals with IDD and mental health needs, and keep them out of systems that weren't designed for them in the first place. Tying that to the programmatic piece is ensuring that counties are well-informed and aware of how diversion centers work, the benefit of them, and when someone that they interact with might qualify and be better fit for a diversion center as opposed to county jail. At the same time, we must continue to expand the outpatient biopsychosocial approach, or OBI model, for people with IDD and mental health needs to support in community-based settings. Increasing funding for OBI sites would allow more people to get care before reaching a crisis point. And finally, none of this works without the people providing direct care. Fair pay for personal care attendants is essential. These professionals support people with IDD in their daily lives, yet they are paid poverty level wages at $10.60 an hour. And without competitive pay, we can't recruit or retain enough staff, leaving people without the support that they need to stay in their homes and communities. And so the bottom line, if Texas wants better outcomes, we have to fund them. There aren't just expenses. These aren't just expenses, they're investments in people's lives, in our communities, and in a system that actually works for people with IDD and co-occurring mental health needs. And with that, I want to thank you all for taking the time to be a part of this conversation. We know that this is a complex issue, and we're grateful to have so many people engaged in working towards this change. And now I'm going to turn it over to Jennifer to help guide us through the question and answer portion of this webinar.
Thank you, Sabrina. Thank you, Alex. Hearing about the possible solutions that exist gives me hope that this is an issue that we should confront and can solve as a state with the right investments. I'd like to ask you guys a couple of follow-up questions to get a better sense of next steps and available resources. To start, how can we do more to keep people with IDD and mental health dual diagnosis before they ever interact with the criminal justice system?
Yeah, I'll start with that. I mean, I think it all ties together with what we've been talking about today and what many of you have been talking about for a real time. It's making sure there's enough mental health providers for people with IDD, making sure group home workers are equipped to handle behaviors of people who also have mental health on top of their IDD, and also like maybe paying them so they continue working. But there are some other things that we looked at in the report. For example, local IDD authorities, which is kind of like your first stop when you need services in Texas, they're not doing comprehensive mental health screenings. They do like a suicide screening, and they ask a couple questions. And if somebody asks about mental health services, they will refer them. They are not sitting down and doing a comprehensive assessment to determine if someone who presents with IDD also has some mental health concerns. Instead, right, like I said, they refer people to the LMHAs. But you know, that creates the opportunity for a gap. in care, because you may refer them, they may not go, or you may refer them, it may get lost, right? If we were able to have both of those things done in conjunction through the LIDA, I think there would be way more opportunity for people here in the beginning before they hit a crisis. Additionally, we could also the legislature could invest in coordinated specialty care teams, which are designed to catch someone within the first 2 years of their first episode of psychosis, so that they can receive access to the care and services they need, and they don't end up deteriorating to the point where, they need a more significant intervention like institutionalized care. Texas currently has 48 of these teams across the state, but there have been studies that show about 100 teams are needed to capture about 3,000 Texans who experience that first episode of psychosis each year. And of course, if you catch someone at their first episode of psychosis and don't let it get worse after that, they are way less likely to interact with law enforcement, way less likely to need institutionalized care throughout their life. It's just much better to get those front-end services as opposed to letting it deteriorate to kind of this no return point.
Alex, both you and Sabrina sort of talked about training and university curriculums. Are there places that train their therapists to work with people who do fall into this category, this dual diagnosis of IDD and MH?
Yeah, it was a little difficult to find somebody who did. But actually, Ohio State University, their psychology graduate program, they have a specific unit that focuses on IDD and mental health. They have a number of professors that this is their only focus. They do studies. So they're really working to train people to work with people with IDD and mental health, because you can still work with them. It just might be different. You might be working with someone who's nonverbal. You might be working with someone who doesn't understand what is going on in their brain, can't explain it, can't elaborate on it. And so they're really focused, not only trying to help people that go to their school, but they go around, they speak, they try to encourage other colleges and universities across the country to develop these programs, or to at least have one professor who sort of specializes in this. But at OSU, students who graduate and are licensed to practice, they have been trained specifically to serve this population. And that's through a number of ways. For example, mentorships, research, internships, practicums. They're really prepared to handle the unique challenges that come with the IDD population.
I'm never above borrowing and stealing other people's good ideas and bringing it to Texas. So I love to hear that there's a program that exists and is doing this work very well. One of the other questions, this was brought up during the presentation a couple different times, but why isn't institutionalized care a good option for people with this dual diagnosis, and what are the better options?
Yeah, thank you for the question. I think that this is an incredibly nuanced question, and I want to acknowledge that institutionalized care often becomes the only option when other community-based services have not been able to meet the needs of individuals with dual diagnosis of IDD and mental health challenges, and is often a symptom of a lack of investment in other less restrictive alternatives. So while these settings that provide institutionalized care may have staff trained to support higher acuity needs, it's important to recognize that they are segregated settings that are the most restrictive environments. And the majority of people want to be able to live in their homes and communities alongside their friends and family. And what people truly need is the support to be able to live within their communities, not isolated or segregated into institutional settings. Better options include community living arrangements where individuals receive person-centered care that respects their autonomy, as well as provides the supports needed, such as specialized behavioral health services that addresses both IDD and mental health needs. these alternatives allow people to live more independently, connect with their communities, and receive those tailored supports that aligns with their preferences and goals.
Thank you, Sabrina. We do a lot of work at the Arc of Texas on different issues. What is the work that we're doing on this particular issue to make fundamental changes in this arena to help people? And what can people do if they need help navigating some of these pretty disjointed programs that are in existence?
That's a good question. I think that the Arc of Texas is working really hard to try and address these issues at the legislative level and working with policymakers and elected officials to inform them about what the real on the ground experience is of people with IDD and mental health conditions. That's a lot of the work that the Arc of Texas does, is to educate lawmakers on what this means. And in addition to that, through the Whole Person Project, we have created a training that is a free 60-minute on-demand course that is available on our website now, called Breaking Barriers. And this course is specifically designed for mental health professionals and folks that work in the medical capacity to serve people with IDD and mental health conditions that maybe didn't go to a specialized program at OSU, specifically to learn about how to interact with this population, but may be interested in learning. And so we are working to try and create that and break those barriers so that clinicians and folks that work in the field feel prepared to meet the needs of this specific population.
Alex and Sabrina, I appreciate you both greatly for the work that you did on this Whole Person Project and for taking the time today to kind of give us a preview or a highlight of the report itself. Before we hop off, I just want to reiterate what Sabrina just said, that there is this training that is on our website. You can also find the full investigative report, a series of brief documentaries with folks who have lived experience, which I think is an incredibly important piece of this project. Those all on our website. You can also hold your phone camera to the QR code that should be on this slide, or perhaps on this slide. So I hope that you guys will avail yourselves of all of those resources that have been built around this Whole Person Project. We're so grateful for the work that you all do in the IDD and mental health space, and the opportunity that we have to continue to partner with so many of you. I do want to do a quick reminder that the registrants will receive an email by tomorrow with this recording, and it will include the slides. And again, I just want to thank everybody for taking time today to learn about this project. I hope that we can move forward and helping to make sure that the right investments and right programs are brought to the forefront so that we can make some of these recommendations come to fruition. So thank you all, take care, and best of luck during session.
Thank you so much.
Thank you.